I welcome Dr. Thomas George. He is working as senior consultant at of glaucoma and cataract, Chaitanya Hospital, Trivandrum, for his keynote address, Rational Diagnosis in Glaucoma. Over to you, Thomas.
Thank you, Vijayma. Good afternoon, everybody. I will be taking you through a few cases to highlight a few points that I consider as important in diagnosing glaucoma. So, one is, first of all, glaucoma is a progressive disease, and one is never sure that we have diagnosed glaucoma until you show a progression. It has to be documented. And things can change over time. So, every visit, please revisit the history and examination, even during follow-up, and not just do an IOP, do a field, and keep them going on for years. Revisit the findings when there's any change, or at least once a year. First, I'll go through a 55-year-old person who has got a transferable job on treatment for glaucoma already for 5 years when I saw him. And it was noted by a general ophthalmologist and referred to a specialist at 50 years of age. IOP was historically 40 and diagnosed as angle closure, and both eyes laser PI was done. Discs were noted to be 0.5 and one eye is advanced with 0.9 cup at that point in time itself. And no treatment for intraocular pressure was there after that, and IOP was 10 within 1 month, and there was some sort of a communication gap, and he never went for any follow-up during the next couple of years. He got transferred, he needs new glasses, so he goes to get checked, 30 pressures both eyes again. And once again, a glaucoma specialist is roped in, and as per the medical report, the fields were the same as before. That's 2 years, no obvious progression on fields. IOP was 12 with the specialist, but because the 30 was recurred, he enlarged the PIs in both eyes anyway. And subsequently, he was put on Brimondin and dorzolamide drops, and intraocular pressure was 10 to 14 for next 2 years. But according to the patient, during that enlargement of the PI, after that, he had severe headache and vomiting, etc. Went back to the hospital, pressures of 50, which was managed with IV and oral treatment. All this was not there in the medical report. And subsequently, he was started on medical therapy. Another 2 years, new town, and he is surprised with another intraocular pressure of 20. Fields are still the same. He is diagnosed as chronic angle closure and advised surgery in both eyes. When people advise surgery, they always seek a second opinion. So this time when he came to Trivandrum for his holidays, he came to me, and vision was 6.6, IOP was 10 both eyes on Brimondin and dorzolamide, 2 patent PIs each in the 2 eyes, and fields were the same right through. All 3 fields with him were the same. PI was patent and the angles were closed. As you can see, the gonioscopy, you can see below the Schwalbe's line is not seen, it's fully closed. But on indentation, you look at the second picture, there's a plateau iris, there's a sine wave sign, the angle is capable of opening all the way. So I decided to try pilocarpine. He was put on 2% pilocarpine. Luckily, the patient is happy with the pinhole effect, and he says he doesn't need glasses to read near anymore. And pressure was 10 mm. Subsequently, we withdrew the Brimondin and dorzolamide, and gonioscopy was open angles, the pressures were 10. So, gonioscopy is one examination that I cannot emphasize enough. Everybody needs to know how to do gonioscopy. Gonioscopy is needed for closure, everybody knows that. But mind you, the sensitivity of Van Herrick's is only around 60%. It's a poor predictor for angle closure glaucoma, and it doesn't tell you that the angle is open if the Van Herrick's is showing a wide angle. You need gonio to show an open angle to even diagnose a primary open angle glaucoma. It's an open angle glaucoma. You have to show that it's open. 90% of the secondary glaucomas, the diagnosis hinges on your gonioscopy findings. Every ophthalmologist needs to know how and do applanation and gonioscopy. Not good enough to know, you have to do it. One needs to see at least 100 normal angles to figure out what normal is to start identifying pathology with reasonable certainty in gonioscopy is not just for glaucoma. There are other findings in the angle which we may pick up for other diseases also. Peripheral nodules, keratic precipitates, peripheral cornea is better seen from the behind rather than in front because you may have a wide arcus, all that's there. So I go on to the next patient I would like to highlight, and that is a 61-year-old diabetic, ischemic heart disease and hypertensive. He had a septic shock post RTA, road traffic accident at age of 45 years, and on follow-up with no treatment with a diagnosis of possible NTG or a one-time vascular event that happened in the hypotension or septic shock. So cup disc ratio, there's a notch, it's an advanced glaucoma again, and dense superior arcuate scotomas, but the pressures being low, 10 to 14, he was just being followed up looking for a progression on no treatment. And the fields were stable, every 6 months we kept doing the fields, and for about 10 years nothing has happened. Then suddenly he pops up with a pressure of 28 in both eyes. Gonioscopy shows a fully open angle, it's not a closure. So we dig into history, took quite some time, and reluctantly he let out that he's been on treatment for a skin disease, eczema with skin creams, and possible steroid response is suspected. Medical therapy was anyway started because the pressures are high, and steroids are stopped, and eventually in 3 to 4 months the IOP is expected to come down, and we may be able to pull out of medical therapy also. So revisit history whenever required. Next I go into a 71-year-old diabetic for 12 years, hypertensive for 5 years, on treatment with POAG for last 30 years, and pilocarpine was drug of choice of POAG treatment in the past, and he was happy on it, so it was never changed. So his pupils are never really dilatable, and suddenly the 14 to 18 pressure which he was going on became 34 in one eye. And there you are, we made a mistake there because we missed the diabetic retinopathy till he threw an angle neovascularization. The good side of the thing is we stopped pylo, dilated him, and did a PRP, and he's okay. There's a fourth patient that I would like to take you through. This is actually a foreigner. She is on treatment at 28 years of age with travoprost for 4 years already. That means 24 years of age she was diagnosed as primary open angle glaucoma based on fields having a superior arcuate scotoma in one eye. Historically, she says even those pressures were only 16 at diagnosis. It's very rare for a young person to have a normal pressure and glaucoma. That itself is a red flag, but the patient is on treatment. And now when I see pressure is 14 in both eyes, open angles, and the discs look normal to me. And this is a OCT. And one eye has got an OCT marked abnormal, and the other eye is absolutely normal. But I'd like to show you OCT of the right eye done again. Can I have a pointer? See, the problem is the segmentation. It's the same scan of the same patient on the same day. Unfortunately, I don't know the point. I'll just walk over. Out here, the segmentation has gone wrong, and it's gone red out here, and one segment has gone red. The same pictures there, the segmentation is correct, and the same segment comes out as green. Anyway, I'm through with it. Thank you. So this is what it is. The segmentation went wrong there. Same thing, same picture, and the graph hits. Whenever the graph hits the baseline down, you have to be suspicious of the OCT. So now we have a patient with normal disc fields and OCT. Stop the prostaglandin analogs. Usually the effect wears off within 1 week. 1 week down the line, she is okay on the pressure side. And she has promised to come back to India once she's off treatment for about 6 months as well. And I don't expect her to become a POAG at this age. So I expect the pressure then also to be normal. So based on a single field, the patient was put on treatment. So investigations can have errors. Do not diagnose and treat individual findings on examination or individual findings on investigations. Do not, this is something that I find a lot of hospitals are doing, do not outsource IOP to technicians. They're very reluctant to record a out of normal range pressure, so they will repeat and repeat and repeat. In some place they will get an erroneous normal reading, and for 3 months you will be thinking the pressure is normal. We need to diagnose patient on the overall patient profile, and glaucoma is a dynamic disease, and until we see progression we are never sure. That has to be at the back of your mind, so we keep revisiting the diagnosis on follow-up. Sometimes we may need to tell our patient much down the line, once his long learning curve on fields goes through and the patient suddenly throws up a normal field 2 years down the line, that we probably were wrong to start with, and we can try cutting down on treatment. There's no shame in that. That's the right way to go about it. You don't want side effects of treatment either. So I go on to the next one. 70-year-old on treatment for glaucoma for 15 years with a combination of brimodin and timolol for NTG. 12 and 14 pressures, open angles, this is suspicious all right, and dense scotomas on fields, practically one-eyed. Once again, this is a foreign patient. We get a lot of Mali patients in Chaitanya, so these are all diagnosed there. Can I have 1 more minute? Yeah. There's dense scotomas on one eye, even the other eye has got scotomas in the arcuate area, but when you go to the OCT, this looks bad, one sector is gone, but look at the segmentation, there's something else going on there. The internal limiting membrane is taking off into the vitreous and the other segmentation comes down here, there's something else going on there, and this is what the patient had, toxoplasma scars. And based on fields, the patient has been put on treatment. Now the flip side is the patient is convinced he's gone blind with glaucoma, so I have difficulty, I don't know if he'll stop treatment. His son is convinced though, and I hope he comes back to me 3 weeks down the line of treatment to check if the pressures are actually normal. So in short, treat the whole patient, not the single findings. Temporal sequence of events may modify one's plan. Gonoscopy and fundus examination are key to diagnosis and management. History is not just for the start, revisit as and when required, at least once a year. Thank you.
Thank you, sir, for the elaborate and informative talk on the intricacies of glaucoma diagnosis. A few points I would like to enlighten is that a glaucomatologist should be a good counselor. There is no hurry in treating starting the treatment, but you have to counsel the patient about the continuation of treatment once you started the drug. That is very important. And also still pilocarpine has a role in the treatment of glaucoma, as sir mentioned. And thank you, sir, for the enlightening the importance of gonioscopy in the diagnosis of glaucoma.